Hello. Hello. होइन गइसक्यो अन छ त भएन त ए हो र खोइ मेरोमा यहाँ त लगभग 1 2
Hey Naveen, how are you?
Good morning, Dr. Sambu.
Hey, good morning, good morning.
Hi,
Or good
Raksha.
evening. Good day.
Oh, so good evening. Yes, yes, of course. Good evening to you.
Nice to meet you. I don't think we've met before.
No, we've not met. Yes. I'm in Viratnagar early, so I was here for a talk yesterday.
Okay, okay.
Nice.
Hey Raju, hey Naveen.
Hey.
Hey Sambu, Naveen. Hey Raksha.
Hello.
Hello.
Hello, namaste सबैलाई. Good morning.
Hello, Subhash. Namaste.
Good morning, Subhash.
So we have
Naveen, हजुर.
do we wait for more or like start now?
नवीन स्टार्ट गर्दै गरौँ. अरु जोइन गर्दै गर्छ हैन.
Okay.
We already waited for 5 minutes. Start गर्दै गरौँ है.
Okay. Sure.
Yes.
ल है त ल गुड इभिनिङ एभ्रिवान अब welcome to the I think this is we are reaching completing second year of ANMF Critical Care Forum. I know we've been doing CME sessions for the last 2 years, mostly critical care and pulmonary sessions. We've been doing it through collaboration committee and Dr. Subhas Acharya, he has been very pivotal in Nepal and America. More Dr. Raju Senchu, we've been working on this, and today we have had multiple sessions so far. We actually started with sepsis and septic shock, and now we're coming to interstitial lung disease discussion today. We always try to bring someone who is very interested in some topics with some research or whoever has clinical experience with certain topics, and any one of you who are clinically invested in any of this pulmonary or critical care topics, you're welcome to let us know, and we will try to accommodate for this CME sessions in future, right? Ani today today it's December 22nd here. अब नेपालमा चाहिँ 23rd भयो. सबैलाई गुड मर्निङ गुड इभिनिङ हैन. आज म चाहिँ ANMF कोलाबोरेसन कमिटीको चेयर छु. नवीन खैनी, म चाहिँ यहाँको पल्मोनरी क्रिटिकल केयरको मेडिकल डिरेक्टर र यहाँको उसमा क्लिनिकल सेटिङ्समा काम गर्ने हो. हामीले चाहिँ टुडे वी आर ह्याभिङ डिस्कसन इन इन्टरस्टिशियल लङ डिजिज एन्ड आजको मोडरेटर चाहिँ डाक्टर रक्षा पाण्डे हुनुहुन्छ. उहाँ चाहिँ पल्मोनोलोजिस्ट, स्टिम पल्मोनोलोजिस्ट इन नेपाल, एन्ड she works in Hams Hospital, if I remember correctly, and she
Yes.
has done fellowship in interstitial lung disease as well. So if I missed anything, Dr. Raksha Pandey, otherwise I'll let you take over from here.
Sure. Thank you, Dr. Naveen. Good morning and good evening to our friends in US. Yeah, so I'm Raksha Pandey. I'm still working in HAMS Hospital, pulmonary and critical care physician, and my interest is in interstitial lung disease. I don't want to talk more about myself, and it gives me great pleasure to introduce Dr. Shambhu Aryal, to this session, and great pleasure to meet another pulmonary physician who's interested in interstitial lung disease. So Dr. Shambhu is a board-certified pulmonologist, internist, pulmonologist, and with an expertise in critical care, interstitial lung disease, sarcoidosis, and lung transplant. So he is the medical director of Innova Lung Transplant Program and Innova Sarcoidosis Center. Welcome, Dr. Shambhu, to this session, and we all look forward to hearing from you and learning about interstitial lung disease from you. So the topic for today is approach to interstitial lung disease in the 21st century. And I think the last decade has seen a lot of exciting new things in interstitial lung disease, mostly for understanding the disease, and of course, new innovations in diagnosis and again, management also, which we in Nepal actually have been able to use the 2 antifibrotics that have been available here. But I look forward to hearing more from you, how you approach interstitial lung disease and how we can also use that in our country here. Over to you, Dr. Shambhu.
All right. Well, thank you, Dr. Raksha, and thank you, everyone, including Dr. Naveen, Dr. Raju, and Dr. Shivash, for inviting me to talk today on ILDs. Let me share my screen and let me know if this is working or not. I'll try to. All right. Is my PowerPoint sharing? Or is it?
Yes.
Is it in the presentation mode or the second screen is sharing? Do you know?
It's not in a presentation mode, Shambhu.
Okay, let me see how I can change that here. So is here, let's see. It comes in screen one, so let me try this. How about now?
Yeah, it looks
Perfect.
good.
All right. Well, thanks again, everyone. So I tweaked the topic a little bit and said how to approach ILDs in 2024, but largely we're going to talk about the approach to ILDs that we do as in a lung transplant center, but also in general. So as Raksha mentioned, I'm the medical director of the lung transplant program here at Innova Fairfax Hospital, where I also direct the sarcoid clinic. It's the largest hospital in the Washington, D.C. metro area. So here's some disclosures. I received some grants and fees from a few of these companies mentioned here, but none of these should influence the talk that I'm giving today. But what I did want to show is the team that we have here at Innova Fairfax Hospital. And for many of you who are interested in ILDs, you might recognize this gentleman over here, Steve Nathan, who I've been fortunate to work with and be mentored by since I joined Innova about 7 years ago. And thanks to the team, we've been able to achieve a lot over the last several years. Here's how our advanced lung disease program is structured at Innova, just to give you an idea. So we have interstitial lung disease, pulmonary hypertension, sarcoidosis, and cystic fibrosis as major disease states that we take care of. COPD also is a big part, with interventional pulmonary doing the lung volume reduction program. But eventually, many of these go on to need lung transplant, and we have a very strong affiliation with the National Institutes of Health to have a research program that's very closely affiliated. When you look at the different certifications of our program, so in the US, there are 75 pulmonary fibrosis foundation centers. There are 119 CF centers. There are 33 WASOG centers of excellence, 82 PHA certified centers, and 75 lung transplant programs. So when you kind of overlap all of these, there are only 13 centers here in the US that are designated with those 5 designations, and we're one of those, and here's Steve Nathan with his trophy. This is the rough breakdown of our patient population in the ILD program. Roughly a third of our patients are related to CTD connective tissue diseases, with a close second by IPF, and then sarcoid and others as shown here in the pie chart. But so here are some of the things that I hope to achieve in the next 40 minutes or so. I hope to show you how we can differentiate ILD from other pulmonary conditions based on patient history and symptoms, differentiate IPF from other ILDs, develop a treatment plan for patients with ILD that includes a pharmacologic as well as lifestyle strategies, and then summarize the importance of the multidisciplinary team in managing patients with ILD based on input and preferences from the patient. So I wanted to start off with a case, and this happens to be a gentleman who's originally from Nepal, who I've had the honor of taking care of. So 47-year-old man who initially had a chest X-ray, some feedback coming through some, I don't know if you can mute those participants. Maybe. Here we go. So a 47-year-old gentleman who originally in 2017 on a routine physical had a mild interstitial markings on his X-ray. He ended up ignoring those, and his provider did as well, because he was very active and had no symptoms. Had a CT scan in 2019 that was actually read as idiopathic pulmonary fibrosis, but again, this was kind of overlooked. And in January of 2022, he actually started to have increased cough that was treated with prednisone by a local pulmonologist. And by March, he was very short of breath with mild activities. SATs would drop to like 70% occasionally as he would exert himself. He was admitted to a local hospital for 2 days and treated with steroids and antibiotics. And then a mutual friend of ours, who happens to be a physician in the area, called me and said, I've got this young guy who seems to have ILD. Can you please see him? So that's how I got him in clinic. On his history, he had no significant medical or surgical history, but he did note he had gray hair in his 20s. And interestingly, his maternal uncle had died in Germany with pulmonary fibrosis. He was a never smoker, and you know, as most of us, he had pigeons in his home in Nepal, but he had not been back home for a long period of time. On exam, his oxygen saturations were 96% on 3 liters per minute, and on auscultation of the lungs, there were inspiratory crackles diffusely, and he had impressive clubbing of his fingers. So with this information, what would you do? As a pulmonologist, as an intensivist, what's your differential diagnosis? What additional testing would you order? Do you send this patient for a surgical lung biopsy or biopsy for short? And how would you treat? So these are some of the questions that we'll address at the end, and I'll tell you what's happened to this particular individual. Going into some definitions, what is interstitial lung disease? Interstitial lung diseases, or ILDs, are a diverse group of lung conditions characterized by inflammation and fibrosis within the lung interstitium, leading to impaired gas exchange. And there are over 200 causes, and you know, these are also called, a more appropriate term is probably diffuse parenchymal lung disease, because the interstitium is just one part of the lung between the alveolar sac and the pulmonary capillary. But these diseases very often spill into the alveolar spaces as well. So DPLDs are probably a more apt term for those. Frequently, we do not know what the cause is, and the spectrum of severity and risk of progression can vary from disease to disease. So you can easily get confused with the alphabet soup of the ILDs, as you can see here in this table over here, many acronyms here, but it's easy to, if you have a methodical approach to ILDs, it's easier. So usually, if you think of this mnemonic, 4 eyes, 5 eyes, and a C and an CN, then you could kind of remember it better. But idiopathic, immunologic, inhalational, iatrogenic, infectious, chronic CHF, neoplastic. So the last 3, not so much. They do have interstitial processes. But when we're thinking of ILDs, we usually think of those 4 categories up at the top: idiopathic, with idiopathic interstitial pneumonias being the major players, with idiopathic pulmonary fibrosis, non-specific interstitial pneumonitis, cryptogenic organized pneumonia, respiratory bronchiolitis related ILD, discomorbid interstitial pneumonitis. Those 2 are smoking related. Acute interstitial pneumonitis, LIP, which is lymphocytic interstitial pneumonitis, PPFE, pleuroparenchymal fibroelastosis, and combined pulmonary fibrosis, and emphysema. So, and then it has immunologic ILDs certainly include the connective tissue disorders, and then there are many of those, of course, as you know. Inhalation include either inorganic or organic, so either pneumoconiosis or chronic hypersensitivity pneumonitis. Iatrogenic related to drugs and radiation, including chemotherapeutic agents and some antibiotics. So those would be the types of ILD we generally talk about. The risk factors for ILDs, as you said, are can be a variable, but generally the thought is in a genetically susceptible individual, an etiologic trigger starts the cascade of inflammation and then healing and maladaptive patterns of fibrosis that eventually leads into fibrotic ILDs in many cases. So these are some of the etiologic agents that you can think of. Specifically, IPF is highly associated with male gender, more so in whites, and older age, more than 70, are big risk factors besides cigarette smoking. If you look at the US, individual ILDs themselves are rare, but collectively as a group, they're not so rare. So almost 700,000 patients or people in the US as of 2019 had some ILD, representing just under 0.21% of the US population. When you look globally, I thought I had a slide here on the global prevalence, so globally, of course, the prevalence kind of varies from country to country and based on different studies. But the closest analogy I see is from India, and based on some of the studies done there, chronic HP, chronic hypersensitivity pneumonitis, seem to be the major player as opposed to IPF, which accounts for a quarter of all the ILDs here in the US that we see that's clinically significant. This cartoon here shows the pathophysiology of ILD in a nutshell. So they're ILDs that are predominantly inflammatory component, and then there are others like IPF, where the fibrosis is a major player. And then there's probably an overlap in some other entities like cellular and fibrotic NSIP, where there's a mix of both. If you look at the national cohort here in the US, published by David Lederer at Columbia and Fernando Martinez in New England Journal of Medicine in 2018, the distribution of ILDs is similar to what we see at our center, with IPF, CTD-ILD, chronic HP, and sarcoidosis accounting for the majority of the cases. The distribution of interstitial lung diseases by age of onset is also important to note. As you can see, younger individuals tend to have more of a diagnosis of sarcoidosis and connective tissue diseases, especially in the females. But as the population ages, it's usually idiopathic interstitial pneumonias, with IPF being the major player. So how do patients with ILDs present? Now, for you all intensivists, obviously, the presentation is pretty dramatic. These patients present with respiratory failure. You treat them with infections. You look at their CT scan, and lack of response to antibiotics, and lack of positive cultures with interstitial pattern when you rule out heart failure and such will give you a clue. But generally speaking, in the primary care or general pulmonology setting, many of the ILD symptoms overlap with several other pulmonary conditions, including asthma and COPD. So chronic dry cough and exertional dyspnea are the two major complaints, of course, with constitutional symptoms of fatigue and weakness. So as far as key elements in history taking, of course, it's important to tease out the details of dyspnea as well as cough, but also when you're examining and taking history, look for the systemic symptoms of connective tissue diseases, including arthralgias, Raynaud's phenomenon, GERD and dysphagia. Medication history is important, as we said, because many of these agents listed here, like amiodarone, bleomycin, methotrexate, macrolide and nigrofurantoin, radiation therapy and immunotherapy, especially immune checkpoint inhibitors that are now used increasingly commonly in the oncology world, are associated with ILDs. Family history is important in certain cases, so as are occupational exposures, either occupational or even domestic exposures of, exposure to molds or down feathers, hot tubs, and such. On physical exam, many of these patients will have symptoms of respiratory distress, pulmonary cachexia. Pulmonary exam almost universally has RALs, except maybe in sarcoidosis, where the exam is often, not as pronounced as imaging would be. Cardiac exam, if there is a pulmonary hypertension, then you can find symptoms or signs of pH. And similarly, you can see clubbing and lower extremity edema, as well as manifestations of connective tissue diseases as well. So just for fun facts here, here's 3 patients with CTDs. The first one has the Groton's papules of dermatomyositis. So that, along with mechanics hands, are common clues for CTD-ILD related to myositis. Sclerodactyly and scleroderma, obviously, and many of you have seen this. A large proportion of our patients are CTDs, so I seem to see that all the time. And then the malar rastral lupus is demonstrated in this third picture here. So what does pulmonary function testing show in patients or people with interstitial lung disease? Of course, it's a restricted process, so there's reduction in total lung capacity, as well as decrease in forced vital capacity, with a normal to increased FEV1 to FVC ratio. Many of these patients will have reduced DLCO, and as a matter of fact, reduction in DLCO alone may be the first manifestation of ILD when the total lung capacity and forced vital capacity are still preserved, just like in pulmonary vascular disorders. And then, of course, with the entity combined pulmonary fibrosis and emphysema, you can actually have hyperinflation from emphysema kind of negating the restriction from the pulmonary fibrosis, and may actually have normal lung volumes, but almost universally, these patients have reduced diffusion capacity. And then something to note, of course, is low baseline lung PFT values, as well as 6-minute walk distance are associated with decreased survival. And there are multiple publications showing a decline in FVC of 10% or more over 6 months is a really poor prognostic marker in patients with ILDs. So what laboratory evaluation do I send for suspected ILDs? First, you want to send a CBC and a Chem7 panel to look for signs of CTD, and then also to tease out certain things that you can see with things like sarcoidosis with hypercalcemia and liver involvement. And of course, you know, it's important to look at CBC and CMP regularly if you're starting immunosuppression for any ILDs as well. Serological autoantibody panel is important, and I don't know what the availability of those markers in Nepal are, but very increasingly I'm sending comprehensive myositis and comprehensive scleroderma panels in many of my patients that I have even a slight suspicion of autoimmune disorders, and actually have a fair number of patients with those conditions. As a matter of fact, I'm in the process of writing a manuscript with 25 patients. Over the last 3 years, I've been here with anti-MDA5 melanoma differentiating antibody 5 antibody-related myositis, which can be a bad player. Urine analysis is important because you can have renal involvement with vasculitis. And, you know, of course, you want to look at some of the markers of heart failure and such to tease out the differentials. What about imaging? So first, this is an X-ray from, these are X-rays from patients with ILDs. You can see their interstitial markings that are prominent with relatively low lung volumes of the second one, especially. Now, of course, high-resolution CT scan is the imaging modality of choice for any suspected interstitial lung disease. It's a non-contrast CT scan that uses thin slices and enhanced volumetric images because chest X-rays lack sensitivity to detect subtle interstitial changes. I have a very low suspicion, low threshold for sending patients to for a high-resolution CT scan with abnormal CT chest or abnormal chest X-ray, or even with a relatively benign looking X-ray, but clinical findings consistent with interstitial lung disease. The differential diagnosis of ILDs, again, many of these symptoms overlap with many cardiopulmonary conditions. So the differential is really broad, and that's why the work that we mentioned before is really important. And if you look at this, a few papers that are published in the last few years, the burden of under and misdiagnosis of ILD is quite huge. The median diagnostic delay range from anywhere from 7 months to 2 years, and the proportion of patients with a diagnostic lag of more than 1 year was almost 50%. Similarly, misdiagnosis occurred in almost 50% of those patients. Something that that's probably important to understand moving forward is also these two conditions, idiopathic pulmonary fibrosis and the newly coined term of progressive pulmonary fibrosis, so IPF versus PPF. IPF, as you know, is a chronic fibrosing interstitial pneumonia of unknown cause that's been around for decades. But PPF was coined in the last couple of years in this paper from the Blue Journal that lays down the guidelines for diagnosis of ILDs. Ganesh Raghu over in Seattle being the primary author in this defines PPF as an ILD of known or unknown etiology other than IPF, who meets 2 out of at least 3 criteria as noted below: worsening respiratory symptoms, physiologic evidence of disease progression, and radiologic evidence of disease progression. So these were the criteria that we used as we enrolled patients into the study called the INBUILD trial, that we enrolled a few patients from our center as well, that I have some results in subsequent slides. And it's important to know because progressive pulmonary fibrosis, regardless of what the underlying primary ILD is, tends to have a poor prognosis, and an approach for that should be different than just immunosuppression. So this is a figure from the ATS guideline on ILD and diagnosis. And then, as you'll see, IPF and PPF are the are very well highlighted in this document, because they IPF obviously is the worst of all ILDs. So if you are thinking of somebody, if somebody's has IPF, you try to look for an association, and then you get a high resolution CT scan. If the CT scan is compatible with a usual interstitial pneumonitis or probably UIP pattern, we go through the multidisciplinary discussion, and a diagnosis of IPF is made. If there's indeterminate for UIP or an alternate diagnosis, so those are the 4 categories: UIP, probably UIP, indeterminate, and alternate diagnosis. So for the latter 2 categories, then you can choose to do a BAL or a transbronchial lung biopsy, or a surgical lung biopsy. You could go through the multidisciplinary conference and make a diagnosis of either IPF or an alternate diagnosis. So this is a helpful flow diagram to have, and so just to give you some examples. So this one, this CT scan has the characteristic honeycombing and traction bronchiectasis, as well as reticular infiltrates that are, and so this would be consistent with the usual interstitial pneumonitis pattern. This one has traction bronchiectasis, but no honeycombing, so this would be probable UIP pattern. This one had just the reticular infiltrates of ILD, but in a, it's just one cut, but apicobasilar distribution, and so this would be indeterminate. And then finally, this end has a lot of ground glass without, more in a central distribution, and so this would be alternate diagnosis, maybe NSIP. So that's how we look into CT scans in our multidisciplinary meetings that we have every month with our pathologists and radiologists, and based on if they have had a histopathology and what the pathologist thinks and what the radiologist thinks, with us kind of leading the discussion as to what their pretest probability for IPF is, we make a diagnosis by plugging those cases into these different boxes. And so, multidisciplinary, discussions are extremely important and have been shown to improve the accuracy of diagnosis of ILDs across many settings. I wanted to introduce this paper that we wrote and published in Annals of American Thoracic Society just a couple of years ago. This was a development validation of a clinical diagnostic scoring system for IPF, and we call it the Fairfax IPF Clinical Scoring System, or FIX. So we had a bunch of patients in our cohort here at Innova, and then the validation was done in 3 different countries, Turkey and Brazil, as well as the center here in the US. And so with this, what we came up was these factors. So everybody who has an ILD automatically gets 5 points, and based on their age, they get certain points. Male gender gets 3 points, Caucasian gets 2 points, smoking history, family history of ILD, exposure, CTD signs, and Velcro crackles are other variables. And as you can see, you can get a score of that you can calculate, and a score of less than 10% or below, the probability of having IPF as the ILD is quite low. On the other hand, if you have a fixed score of more than 20, then you have a 97% chance of this being IPF. And this is something that we routinely use in our clinical practice and might be helpful to implement. You also know about the GAP score, gender, age, and physiology score, based on their sex and age and physiology. And of course, you can get a total of eight points. And this has been around for some time, over a decade now, and predicts the mortality based on the points that you can get, the patient can get. So this is a helpful tool to have, but we actually modified this tool in the last couple of years and published this in Thorax as well as ERJ Open, called the DoGAP index. And so the D and O stand for distance oxidation. So if you have less than 250-meter walk distance on the 6-minute walk test, you get 5 points. And if you have exertional hypoxemia needing oxygen, you get another 5 points. So you, instead of 8 for the GAP, you can get 18 points. And as you can see here, stage 1, 2, and 3, we've categorized into below 4, 5 to 10, and 11 to 18 points. And we showed that it's shown here in this Kaplan-Meier curves that stage 1 has the best prognosis, with stage 3 having really poor prognosis, with a 3-year mortality as noted here, for stage 1, 16% versus 72% for stage 3. So this is probably another good clinical score to be able to use for IPF. Now, when you look beyond IPF into the other fibrotic ILDs, the so-called progressive pulmonary fibrosis, they're probably very similar in terms of in their clinical course. But generally, when you think, and this is from Whitney Brown, who is a partner of mine here in our practice, and she wrote a nice editorial for an article in the Annals of the American Thoracic Society in 2018, where she said, she titled this "Demystifying and Deconfusing Fibrotic ILD." So when you look at ILDs, of course, inflammation is a big part for many ILDs, but then many ILDs have fibrosis as the major pathophysiology. So idiopathic interstitial pneumonias, there are some that are predominantly fibrotic, and many that are predominantly inflammatory. There's CTD-ILD, much of which has inflammation, but then end-stage cases can go into fibrotic diseases and progress into the PPF phenotype. There's NSIP, IPF, chronic HP, early interstitial lung abnormalities, which is basically and these are dubbed ILAs, which can progress into frank ILDs in some cases, occupational lung diseases, and then there's the black box of unclassifiable. And of course, the last few years after this was written, the post-COVID ILD became a significant group as well. But when you look at the disease course of ILD, the ILDs fall in a spectrum of severity, and then the clinical course can vary from patients to patients. This figure is from a book chapter that I wrote with Steve Nathan. You can have spontaneous resolution in some cases, stable or improving disease with treatment, progressive fibrosis, and others. But when you look at IPF, virtually all cases are progressive, and 80% of those cases progress rapidly. So whenever I go out into outreaches for my lung transplant center, I'm talking to pulmonologists to refer them for any patient with IPF for lung transplant evaluation ASAP. But so here's the three-pronged approach for the interstitial lung disease diagnostic team. First, the clinicians, pulmonologists, we're a major player, part of that, and the other two players, of course, are radiologists and pathologists. And you always need to think of the patient being in the center, and communication among multidisciplinary teams is essential to an accurate diagnosis. And all ILD centers, at least here in the U.S., have a well-oiled, multidisciplinary team helping in the diagnosis of these of ILDs. So switching gears, let's spend a few minutes about on treatment of ILDs. So goals of treatment for ILDs are listed in this graph here. This is taken from the Lancet 2022 review. So we basically want to address triggers if they're relevant. So chronic HP, somebody's been continuously being exposed to parakeets, you want to take them away from those. Treating symptoms, reducing inflammation, of course, if there's inflammation, the predominant cause, preventing or slowing fibrosis and progression, treating comorbidities, because many of these patients have a lot of comorbidities that may, and then toxicities of therapies as well. And eventually, of course, our goal is improving the quality of life and function of those patients, as well as giving them longer life. So what are some of the approaches we can take? So for mild cases of ILD that are predominantly related to inflammation, like CGD-ILDs, just routine monitoring of lung function might be the best approach, because a treatment is not without side effects, and not all of these cases progress or progress at least rapidly. Supportive care is important for all of these patients, including vaccinations, pulmonary rehabilitation, patient and caregiver education, psychosocial support, because a lot of these patients have anxiety and depression. And then, disease-modifying treatments. So for inflammatory ILDs, immunomodulator therapies are important. For fibrotic disease, of course, antifibrotics are the cornerstones of treatment. Of course, you got to think beyond medications when these seem to fail. What does non-pharmacologic treatment include? We kind of touched on some of those in a prior slide. So smoking and vaping cessation is extremely important, because almost all ILDs are associated with smoking. With very strong associations with RB-ILD, DIP, and IPF. Removal of potential triggers, vaccinations, and all these other things that we kind of mentioned about before. Management of comorbidities is extremely important. So when you look at some of the IPF clinical trials or IPF reviews and retrospective trials, there's association of GERD and sleep disordered breathing in 90% of the patients with IPF. Say, for example, pulmonary hypertension complicates a lot of these patients. Lung cancer is, risk is increased in patients, especially with a strong smoking history, and mental health disorders are also extremely common. Steve had edited a book on IPF a few years ago, and we wrote a big chapter on the phenotypes and comorbidities of IPF. And this chapter and this book may be a good resource for any of you that are interested in further reading on IPF. As far as pharmacologic treatment options, I touched on this already. So for IPF and PPF now, antifibrotic therapy is what we want to start early. Non-IPF ILDs, so clinical monitoring if they're very mild, and if you think the treatment risks outweigh benefits, and at some point immunomodulatory therapy is helpful. And obviously, when they progress into this PFF or PPF rather, antifibrotic combined therapy might be the way to go. What are some of the immunomodulatory therapies that we use? So the common therapies that are used are corticosteroids that work in most cases, mycophenolic acid or Cellcept, at least here in the US, azathioprine or Imiran. And then some of these other less commonly used agents, including rituximab and tocilizumab, tacrolimus, IV immunoglobulin, Many of these are reserved for more severe cases, usually like myositis, especially like MVF5 or the more aggressive myositis is when I would be using those for immunomodulation. If you look at what's been done over the years, so in the last 30-some years, these are some of the trials that have happened in the field of IPF, eventually leading to the Impulsus capacity and Ascent trials that led to the approval of the 2 antifibrotic therapies that we now have. So I remember this very clearly back in May of 2014, the New England Journal of Medicine, the same issue had these 2 landmark articles on pirfenidone and nintedanib showing improvement in or reduction in decline in forced vital capacity in patients with IPF. And soon after, the FDA here approved those 2 therapies for treatment of IPF. I wrote a review a few years ago on emerging drugs for treatment of IPF, and then summarized some of the research that was happening around that time. But this review has a good review on the landmark research that has led to the approval of these 2 antifibrotic agents that we have. So nintedanib is indicated not only for IPF, but there have subsequently been 2 studies: the Census trial for SSC, scleroderma ILD, and the INBUILD trial for the progressive fibrosing ILDs. It's a tyrosine kinase inhibitor targeting multiple growth factors. Pirfenidone, we do not know the exact mechanism of action, but nintedanib is twice daily, pirfenidone is 3 times daily. Nintedanib causes more of diarrhea, pirfenidone causes more of upper GI side effects, as well as skin sensitivity. So those are some of the side effects that I take into account choosing one drug over the other. And I'm happy to learn that access to both of these drugs are available in Nepal. So I'm sure you guys are using those as well. I wanted to highlight the INBUILD study because I was closely associated with this trial from our center. We enrolled 3 patients in this out of these very many patients. But as you can see, this looked at a different ILDs, including chronic HP, autoimmune ILDs, idiopathic interstitial pneumonias, other ILDs, including sarcoidosis. And what it basically showed is over a 1-year period, the reduction in forced vital capacity was significantly lower in the nintedanib group, and especially if you had a fibrotic pattern on the CT scan, that was more pronounced. So based on this, it's been approved for progressive pulmonary fibrosis, and we use that. And then I also wanted to touch quickly on pulmonary hypertension, ILD, and then acute exacerbations of ILDs, because those probably are going to be relevant to you as intensivists and also taking care of these patients. But when you look at pulmonary hypertension in patients with interstitial lung disease, the estimated prevalence varies largely depending on the cause of ILD, the disease severity, and the diagnostic modality that's used, either echo or EHR-CAP. But if you look at all these studies listed at the bottom, at initial diagnosis, about 10% of patients have PH-ILD, but by the time they're listed for transplant, almost 90% of those people have pulmonary hypertension. So why do I mention this? I wanted to mention this because of this article. So up until 2 years ago, we did not have any approved therapies for pulmonary hypertension related to interstitial lung disease. But this landmark article called the INCREASE study, for which Steve Nathan was the principal investigator, established the role of inhaled treprostinil in pulmonary hypertension due to ILD. And the main primary endpoint for this was difference in 6-minute walk test. And so the change from the baseline was 31 meters with a minimal clinical important difference of 30 meters. So this was a clinically significant distance, and based on this, inhaled Tyvaso or treprostinil has been approved for group 3 pulmonary hypertension due to IPF, and and this is something we're routinely using in our clinical practice here. Now, of course, as intensivists, why does ILD matter to you, or how do patients with ILDs present? And this is a nice review from Krishnan et al. From CHEST from this year that summarizes as well. So you're basically looking at a patient with an acute respiratory deterioration with extraparenchymal causes like pulmonary embolism, pleural effusion, and pneumothorax ruled out, and you see new bilateral ground glass consolidations that is not explained by volume overload, then you got to think, is this an acute ILD exacerbation? Now, if the patient has known chronic ILD, then you got to think at some of the potential causes of those CT scan findings, including infection, aspiration, drug toxicity like amiodarone, if they are on it for AFibs, or for example, recent surgery or procedure with anesthetic or a flare related to that. And then CTD-ILD, potential causes being in patients with those, because these are immunosuppressed, opportunistic infection being there, anti-MDA5 that I kind of briefly mentioned, and then some other medications that could potentially cause some worsening. And many a time you are faced with a newly diagnosed ILD, and then you got to do this workup that we kind of talked about in the previous slides. That includes good history taking, serological workup, as well as good history, including family and autoimmune history. Acute exacerbation of ILD or IPF for that matter, these are some of the criteria that have been laid out over the years. Basically, you're looking at somebody with more than 30 days of symptoms, with new changes in the CT scan, no evidence of pulmonary infection, or other alternative etiologies that we talked about. And so how do you treat acute exacerbations of ILD? Prevention is better than treatment, as they say. So, nintedanib and pirfenidone have been shown to prevent acute exacerbations of ILD or IPF at least. So those are important considerations. But as far as therapeutics, we have very little, unfortunately, for treatment of acute exacerbations of ILDs. Corticosteroids are used at most centers, and then many centers would try to do even more augmented immunosuppression. And then eventually mechanical ventilation and ECMO, bridging over to transplant, or unless you think, there's an ILD like CTD-ILD that's presenting with an acute flare that you control with immunosuppression, then you're looking at mechanical ventilation and ECMO as a bridge to recovery. So this, I found this review from this year that summarizes the ICU management of ILDs very well. So if you have an acute exacerbation of ILD, like we talked about, respiratory support with nasal cannula, high humidity, high flow nasal cannula, which I understand is available in Nepal now, as well as NIPPV. We try not to intubate those people unless in those two situations that I mentioned about, if these are good candidates for transplant and we bridge them from mechanical ventilator or ECMO over to transplant, or if we believe there's a reversible etiology that we hope to reverse. And of course, depending on what exacerbating factors there are, you treat those conditions as outlined here in this figure. Couple considerations that I wanted to point out. So high flow nasal cannulas, the use has been associated with fewer discontinuations and increased oral intake and better communication with patients compared to NIPPVs. So, they have a special role now. But acute exacerbations of ILDs have a poor prognosis. The short and long-term mortality is quite high, 78 and 96 for 1 and 6 month mortality, especially in patients with who require invasive mechanical ventilation. So that's why you got to be clear upfront with the patient and the family when you're looking into intubate these patients. You know, much of this is ARDS care, avoiding large fluid boluses, using diuretics as needed, treating underlying infections and such. And then there's always a question of, is there a role of anticoagulation? And there is really no role of therapeutic dose of anticoagulation unless there is other reasons to do so. We looked at the Pulmonary Fibrosis Foundation registry just a couple of years ago, and you know, what we found out was the need for anticoagulation for whatever other reasons was a poor prognostic marker in those patients. So that's important to know, but and it's important to use DVT prophylaxis routinely. When you look at the mechanics of those lungs in patients with ILD or fibrotic ILD, they're much worse than patients with those ARDS baby lungs. If you look at the stress that develops with any amount of strain compared to healthy and ARDS lungs, it's much higher in patients with fibrotic ILDs. And naturally, I know there's a higher risk of complications of pneumothorax, which can be incredibly hard to treat, you know, difficulty weaning from the ventilator for this reason. So we're getting close to the hour. So let me wrap up with with what happened to my patient. As you recall, for those who joined later on, we're discussing a case of a 47-year-old from Nepal, male from Nepal who lives here in the U.S., who had developed interstitial markings on his chest X-ray that were ignored, but subsequent CT scans showed IPF. The general pulmonologist actually did not, unfortunately, refer him on time to an ILD center or a transplant center. So by the time he presented to us, he was in dire straits, needing you know, 3 liters per minute of oxygen at rest and up to 6 or 8 with exertion. And he had a rapid decline over the next few months. And fortunate for him and us, we're able to help him. But he had some family history of pulmonary fibrosis. So he was admitted to Nova Fairfax Hospital after the initial clinic visit with us. So I admitted him and sent him for an expedited lung transplant evaluation, after which he was able to briefly go out on nintedanib, but it was a little too late, you know, too little and too late. And then probably the nintedanib did not have much of an effect in his disease course at that point. So he had to be readmitted shortly after with progressive symptoms, and his lung functions, his FVC had declined another 20%, and he was actually needing a whole lot of oxygen. So I placed him on high humidity, high flow nasal cannula, and listed him for transplant. Unfortunately, he had to go on ECMO while waiting for transplant. And you know, 2 weeks on after getting on ECMO, he finally got a good set of lungs and underwent lung transplant. And you know, to my surprise, in less than 2 weeks after transplant, he was able to discharge from the hospital and go home. And a year and a half later, he's doing very well, working full time with his family, and it's been one gratifying experience. So with that, I conclude here. Here's some pictures from the DC National Mall. Our hospital, Nova Fairfax Hospital, has been ranked #1 hospital in the DC metro area for the last 8 years or so, with obstetrics and pediatrics being really in the national ranking, and we're consistently high performing in the field of pulmonology as well. So with that, I will stop sharing and take any questions from you all.
Okay, thank you, Dr. Sambu, for such a clear and concise presentation on this very vast topic of ILD. I see a couple of questions in the chat group, which I'm going to lay it on you. Dr. Dipesh has a question. How does COVID-19 impact individual with pre-existing ILD? And what specific considerations and treatment strategies should be employed to manage the dual challenge of COVID-19 and ILD?
Hi, Ditesh. Hey, good to see you virtually on Zoom. It's been a while. So this is an excellent question. So early in the COVID pandemic, of course, just like you guys, we were faced with this question, and I actually had a few of my patients who had pre-existing ILD that came with COVID and had a lot of had bad flares. And then there were patients who had no ILD and then came with COVID ARDS and developed post-COVID fibrosis, some of whom ended up needing a transplant, some of whom actually improved, and I'm following them in the post-COVID clinic. So it's a tough one. I think generally our approach has been to treat them with antiviral therapies and steroids, as shown by the recovery trial in some of those people or in those sick people. And then once they cross the 3-week time frame, if they're still not making much progress, we do an early evaluation for lung transplant. If they have improved, then we try to get them out. We used to use a prolonged taper of corticosteroids based on some of the findings that showed organizing pneumonia in many of those patients. We tried to use antifibrotics in some of those, but then it's very hard for those to be paid. So there's actually an ongoing study for post-COVID ARD or ILD for these antifibrotic therapies. So it's basically being a wait and watch approach. If they get better, maybe with a corticosteroid taper, or if they have bad COVID ARDS or post-COVID fibrosis, we work them up for lung transplant early. We actually wrote an opinion piece on chest early in the pandemic from our center, along with Ankit Bharat at Northwestern, who did most of the COVID lung transplant work, and it's under How Do I Do It, COVID and lung transplantation. That might be a good reference for you.
Yeah, I have noticed, like, if we also did a lot of HRCTs during COVID, and then we found, quite early on in their disease of COVID-19, they had fibrotic lung disease, which they probably had an underlying ILDs. And what I noticed on the follow-ups of COVID-19 is the pure COVID-19 fibrosis, actually, they do get improved, in 1 to 2 years, the CT actually, even the fibrosis actually resolves. So the ones that progress, I think they either are the, susceptible hosts for ILD, that they go into progressive disease. And I don't think pure COVID-19 fibrosis, actually, the antifibrotics, I think it'll be a negative study. We're still waiting for the results.
Yeah. Actually, I'm with you on that one. That's exactly been my experience. It's actually totally changed my thought on what is fibrosis in a CT scan.
Yes.
Basically, the fibrosis has kind of gone away, as you said, in many of these patients, and it's been fascinating to see those people. And then I keep arguing with Steve Nathan here and Chris King. Maybe not all fibrosis that we see on the CT scan is fibrosis.
Exactly. Yes.
And not all ground glass is ground glass, because some of that is fine fibrosis. So, but yeah, our experience has been very similar to yours, and I'd be curious to see what.
Yeah.
It might be hard to tease out, individuals with underlying CTD predisposition versus just pure COVID, but that's an interesting thought there.
So our in our practice, I have around close to 8 to 10 patients that we've been following since Delta waves with COVID, and at that time lots of older patients died, but the younger ones, 40, 45, that needed trach, long-term hospitalization, three months, 6 months, and they went to rehab. And I think we pretty much were very aggressive in pulmonary rehab, nebulizers, and other airway clearance therapies. Now, like, those who were on 6 to 10 liters oxygen are almost off oxygen for most part. Sometimes they are with activities, they are still using oxygen, they still have limitation of life, activities of daily livings, but most of them have vastly improved, so COVID is a different picture here, it's not the same as regular ILD.
Yeah, and then I look back, I trained during the 2009 flu pandemic, and we had a very similar population there, and there were some young people that I thought would never get off the vent, and they actually got better. So in some ways, it wasn't surprising to me. Some of those folks with COVID actually improved, because that's what we'd seen with the H1N1 in 2009, but of course this was a much more impressive population.
So we do have few more questions. Dr. Sushil asks, in proning of ILD ARDS, have you noticed any difference in recruitability in non-ILD ARDS and ILD ARDS?
Well, so I'll say, so although I trained in pulmonary critical care, I practice very little critical care now. So the other intensivists would probably have to, answer. But I know that the data with proning was positive for ARDS. Now, whenever I look at our, that extreme of patients with ARDS, that have previous underlying ILD, I'm already thinking about transplant and working them up towards transplant. And rather than proning, my approach is trying to get them on ECMO and trying to rehabilitate them so we can make them lung transplant candidates. But what you suggest there is probably true. These have stiff lungs, even much more stiff than in a regular ARDS, with all zones kind of involved. So it's probably a different beast in there. I don't know if anyone else.
I mean, I think the recruitability for, well, ILD, they're non-recruitable because they're stiff because of the fibrosis and not because of the ARDS. So it's quite challenging to manage the mechanical ventilation for ILD exacerbations.
Yeah, and then something that I see
nightmare
routinely
for the intensivists.
Yeah, something that I routinely see as a corollary of that is when these patients get the pneumothorax, you cannot
Yes.
get the lungs up. It's almost a death sentence. So I think it's a very similar phenomenon there.
Another question is, when dealing with hypoxia with high flow nasal cannula or an IV, when do we decide to go for intubation?
Yeah, so as I said, in somebody with pre-existing ILD, I'm always very, very nervous about intubating those folks, unless I see one of those two situations we talked about. And I remember this case of a young woman that came from Centera, Norfolk, which is like 5 hours from here, on the eastern side of Virginia. And they've got a great hospital system in there, but they don't do a transplant. So they sent this lady, and she was so sick coming in. She was so hard to ventilate. I talked to the intensivist, and we ended up ECMOing her. Sure enough, she came positive for myositis, and with immunosuppression, we were able to get her off. So that's one population that I think about intubation as a bridge to recovery. And then, as I said, bridge to transplant would be the other situation. But outside of that, it always makes me very nervous to intubate those people. And I have a candid conversation with those people and say, hey, if you get intubated, your chance of surviving this is quite low. And we may be doing more harm to you than good. So we try to kind of manage them with high flow nasal cannulas and in a non-invasive ventilation as far as possible. But again, something that I always wonder is what is the, and as we learned during the COVID pandemic, what's the role of spontaneous induced lung injury, and what's the role of high amounts of FiO2 kind of perpetuating the lung injury. Those are the two things that I always wonder about those patients, but it's a tough situation.
Yeah, I think the intubation, they do best for NSIP like patterns, or like you said, anti-MDA5 myositis patients. We do have those. Actually, I have 2 of those in my cohorts actually. So I think in Nepal, most of the ILDs are the epidemiology may be similar to the West. Actually, it's just that we have not been able to diagnose them in detail. I think there's another question for you regarding biopsies, that we've been moving away from surgical lung biopsies more and more. And the question is, can you tell us a little bit about VATS versus cryobiopsy versus avoiding any biopsies at all?
Yeah, no, that's another great question. I mean, so generally, I think based on some the experiences that's been accrued over the years, if we believe somebody's got idiopathic pulmonary fibrosis, we do not want to biopsy them. So that's why whenever I look at a CT scan, of course, I routinely look in those 4 categories to say, is it a UIP pattern? Is it probably UIP? Is it indeterminate, or is it alternative? And then, so if it looks like UIP or probably UIP, then the pretest probability of that being IPF, in an older male, say for example, is so high that and the risk of having acute exacerbation with a biopsy is so high, I almost never send them for biopsies. Now, even before biopsy consideration, I routinely send immunologic workup on those patients, and so especially like young females. That looks, the pretest probability of this being connective tissue disease, ILD, is so high. I pick and prod and examine them and send for serology markers, including like myositis and scleroderma panels. And if they turn positive, there's no need to send them for biopsies, because you're immunosuppressing them anyway. And in many a time, patients come to us because they've had a biopsy when they didn't need in such a case, and then come with a complication of that, and really breaks my heart. As far as when you, for the indeterminate or an alternate diagnosis where the patient really wants something, as studies shown, like just transbronchial biopsies, and then I'm saying just regular forceps biopsies, not cryobiopsies, don't get enough of a sample. So while we do that for maybe BALs, and then looking at CD4 to CD8 ratio, distinguishing sarcoid versus chronic HP might be helpful. That's the role of bronchoscopy that I use. As far as cryo, I know there are many centers that do cryobiopsies here, but we have a really good experience with VATS biopsy. Actually, our surgeons actually do VATS the same day and discharge the patients the same day, with much less risk of bleeding and such. So VATS biopsy has been our go-to, and then that's really been our approach. But I know that many centers actually do cryobiopsies, and there's ample evidence that that's actually as good as VATS biopsy in many of those papers. So I think that's probably okay to use if that's what you have available.
Yeah, I think I use very little of I do very little biopsies here, lung biopsies, because cryo is not available here. So I used to do cryo, but then it's not available in Nepal. So, and TBLB, just the normal TBLB actually is pretty useless, and then you risk pneumothorax and all for these patients. So bronchoscopy roles, I think, comes as far as BAL. BAL can be, quite helpful, especially for lymphocytosis. And we do see a lot of HPs here.
Mm-hmm.
And sometimes, in ICU scenarios, acute eosinophilic pneumonia can be, we do have, and quite a few, pneumonia being the most common diagnosis in ICU. If it doesn't smell like pneumonia, it probably is not infective pneumonia. So if the patient doesn't have fever or cough and all, but we do see a lot of, infiltrates in the X-ray, I think we should think of interstitial lung disease here. And a lot of times we do, come across a lot of these patients who don't actually, just the pneumonia is just in the X-ray or the CTs, and nothing else matches. So I think we should think of interstitial lung disease in these scenarios. And BAL, of course, weighing the risk versus benefit of desaturating the patients. I agree with you, BAL probably is as far as we can go in terms of enhancing our diagnostic facility.
Absolutely,
Um,
absolutely. And when you
yeah.
said that, it reminded me of when I was in fellowship at an attending teach, whenever he was teaching us to read X-rays and CT scans. There were 5 P's of mnemonics for aerospace disease in evaluation. So of course, infections, non-infectious inflammation, so pneumonia, pulmonary edema, pulmonary alveolar hemorrhage, alveolar proteinosis, and then rare pulmonary tumors like. So I routinely mention that to my trainees here, and then make sure they go through those 5 Ps as they're looking at through the X-ray, and make sure they go through other ancillary evidence to kind of tease out what it could be.
So to answer Dr. Naveen's question about the prevalence of ILDs in Nepal, which may interest Dr. Sambu also. So we do have a lot of ILDs in Nepal, and I mean, maybe because I see ILD patients and I see more of those, but most of them present quite late, actually. I see ILDs when they're already fibrotic and they're already in UIP pattern, I'm always happy when I diagnose ILD first. They come with just cough that is not getting better. Almost all of them are being treated by with inhalers, and quite a few as heart failures. Regarding the epidemiology, we see a lot of connective tissue disease. ILD is quite common here, and we have the bimodal distributions in the females. So I have a lot of middle-aged women actually who have connective tissue disease, ILD, or at least IPAF, flavor of connective tissue disease. And another large chunk is of fibrotic HP. So, by the time they come to us, they're mostly fibrotic. And of course, sarcoidosis. But we actually see sarcoidosis quite early on, because quite a lot of our, they have their chest X-rays as a medical, when they go out.
Right. Mm-hmm.
Yeah. So that's when they come, and we see mostly in stage 1 or stage 2 of sarcoidosis, and we usually don't need treatment for that, just follow-ups. IPF, I'm sure there is, but I have noticed that it's not as high prevalence as in the West. But when we see a lot of upper lobe changes, it makes me think it's not IPF, even when they have a lot of UIP pattern, and quite a few of them are either HP and come in late because of HP or even sarcoidosis. A lot of young males do have pneumoconiosis related, disease, because they go to India, the sandblasters and the genes, and they work in the coal mines, and also those are mostly what we see. And because they present quite late, not much could be done. And but I'm glad we do have antifibrotics here. Which is quite expensive, actually. So again, they usually cannot afford it for too long, and then they come off it. But yeah, those are mostly the prevalence that of ILDs that we see here. Unfortunately, there's not any registry here. I keep my own registry, so it's just a single person, single center registry.
No, that's very helpful, actually. I mean, here in the DC metro area, there's a big Nepali population. I actually have 5 people of Nepali origin that have ILD.
Oh, okay.
I have one with sarcoid, primarily cardiac disease.
Yes.
I transplanted a 67-year-old gentleman with progressive pulmonary fibrosis. And interestingly, his 2 sisters actually just passed away from pulmonary fibrosis. So there's probably some hereditary component to it, and maybe short telomeres.
Yes.
Another gentleman that I just mentioned, the lung transplant. And then I got a young one who's got this idiopathic syndrome of bronchiectasis. I mean, not really ILD, but job syndrome that we're working towards transplant. So, it's a relatively much smaller population, but I see the flavor the ILD, advanced lung disease,
Yes.
among our countrymen, even here in the DC area.
It's very common actually, and I'm sure short telomere is also very common, because I do have patients with premature graying and all, and I do tell them, you probably have this, syndrome, but we're not able to send, for genetic testing and stuff like that. So yeah. I think there's probably, okay, there's one last question. How much of FiO2 and SpO2 recommendation in HFNC or NIV?
I think that's always a balance between, how, again, high levels of oxygen are toxic, right? Especially in those patients that are undergoing flares. I don't think there's any publication as to the deleterious effects of those high amounts of oxygen. Personally, I believe that we use too much of oxygen in those cases, and that probably does more harm than good. I usually titrate them to maintain a saturation of just around 90 to 95%, as the critical care literature suggests. So just I titrate them based on that. I don't know if there's any hard and fast recommendation outside of that, really, not that I know of, at least.
Okay, I think everyone wants to finish this on a Saturday here.
Yeah, I know.
Thank you so much, Dr. Sambu, for this excellent talk, and I enjoyed it a lot, and I think a lot of our audience also enjoyed it. And thank you, American Nepal Medical Foundation, for this was my first time, logging in, but I think events like these are very important and very educational for us here also, and to share ideas and how we can improve our quality of care here and learn from each other. Thank you very much, and have a good evening, good Friday for our friends in US, and good Saturday for us over here.
Yeah, no, I want to echo the same sentiment. I think we could actually start collaborating, on some research and share experiences. And I think what Raju and Naveen and Subhash have done over the last 2 years, this is really commendable. There've been some excellent talks that I've been able to listen on to, and it was really a pleasure to come and share our experiences here. All right.
Thank you,
Thank you,
Sambu.
everyone.
Thank you,
All right.
everyone.
Thank you,
Thank you,
Rohit.
guys.
We should be doing more.
All right. Bye-bye.
Good
Bye-bye.
night.
Thank
Have a
you.
good day.
Thank you all. Thank you. Bye-bye.
Thank you. Thank you, Dr. Akshay. Thank you, Subhash. Hazda, thank you.
Okay, Naveen. Good night.
Good night. I'll talk to you tomorrow.